So I think what this brings to mind for me, again, just getting more broadly philosophical, is it's so interesting how much we need, and I think specifically in the US mentality before we change our practice. Because just personally, I think this is a that met its primary endpoint. We're talking about 2.5 less weeks of treatment. So we're decreasing treatment by, about a third of the time that we're asking patients to come, with no appreciable difference, even by 6 months in side effects. So for me, I would really lean towards this being my standard in my practice, with the caveat I don't actually treat prostate cancer in my practice. But if I did, to me, this seems almost like a slam dunk win for patients. I'm not sure. Again, this is getting a little bit more philosophical, but Dr. Gillespie recently, one of my colleagues did a paper recently, basically an editorial with pointing to a lot of data on how slow we are on the uptake of randomized trial findings. So for instance, in breast cancer, we all are familiar with fast forward, but yet so few of us are using it, even with 5-year outcomes, with the reasoning, oh, well, maybe at 10 years, it'll be different. Maybe at 15 years, outcomes will be different. Looking back at all breast cancer trials, there's been no difference detected after 5 years. If there's not a difference at 5 years, there's neither one at 10 years or longer. So I think, especially considering the EQD2 is higher, I think we're really reaching to think that biochemical failure rates may separate in favor of more protracted treatment at a later date. That's just something I'm throwing out there. I think it's interesting how much, because I agree with Caleb's interpretation of what the author and discussant said. They were very hesitant to recommend it as a new standard of care.
Yeah, I mean, I think those are great points. And, probably if we opened up the floor to everybody, you'd get a lot of interesting thoughts on that. But I agree with you in 100% follow the logic. I think another thing that's important is we've got the SAC 910 trial that was published this year, looking at post-prostatectomy treatment in the salvage setting, comparing 64 gray to 70 gray in conventional fractionation, and there was no biochemical endpoint difference, biochemical control difference. There was an increase in late grade 2 GI toxicity. And so I do think that I certainly understand some hesitation about adopting this specific regimen that has an EQD2 at 71 that's very similar to the 70 that was just tested and published on, having some increased toxicity. But there probably is an EQD2 equivalent hypofractionated dose that would be very effective. And I think that's, also worth keeping in mind as we sort of sift through it. But it is interesting. Laura, what was your major in college?
It's philosophy.
Okay, right. She is philosophical. Okay. Want to go to the next one? Okay. All right. So this is the CROG 0806 study. Caleb, you want to do this one or Laura?
Might have lost Caleb, but yeah, I can summarize this one.
Sure.
While he gets back on. So done in Korea, which is actually a fabulous radiation oncology working group that does a lot of really practical studies in randomized fashion. Can we go to the next so I can remember the details? Okay. So most of us are probably familiar. There have been a couple of trials done. A French one comes to mind from several years ago, looking at do we really need to include the internal mammary nodes when we do regional nodal radiation? Because as we all know, all of us have done regional nodal breast radiation. And of course, it's the internal mammary nodes that really give us all the headache when it comes to planning and trying to limit lung and heart dose. And, at what benefit are we doing this, particularly when we look at recurrence patterns, actual isolated recurrences in the internal mammaries is exceedingly rare. But historically, especially in the US, it's always been an all or nothing game when it comes to clinical trials with regional nodal, basically always including the internal mammary. So this is a very practical trial, looking at women that merited regional nodal radiation. Do they need to include the internal mammary nodes or not? So in this trial, no one received, so there's 747 women, no one received neoadjuvant chemo, so they all received adjuvant chemo. So we have, this in no way answers any question about how we need to approach pathologic response to chemo. And again, everyone received radiation to the breast or chest wall and the supraclav. So supraclav and axilla was always intentionally included. And then there was a one-to-one randomization of, intentionally including the internal mammary nodal volume or not. So again, kind of similar to the first trial, they had a pretty ambitious primary endpoint. But I think one might argue the primary endpoint is merited. So they wanted to demonstrate an improvement in disease-free survival of 10% among these women, just simply with the addition of internal mammary nodes in the treatment volume. And, as probably most of us would have suspected, they were not able to demonstrate that. So at 7 years, yes, there was a numerical improvement in disease-free survival, but only of about 3%, as you see there. Breast cancer mortality, also non-significant difference, was a numerical improvement of about 2.5%. But what I think is certainly the most interesting finding is that there really seemed to be a bigger separation seen, particularly among the women with central and medial tumors. So, they looked at number of axillary nodes involved, et cetera, but this was really the clear distinction, was the tumor location. And, that makes sense. Who's most likely to have occult internal mammary node disease that's not caught on sentinel node or axillary node dissection. So there's actually a 10% improvement in disease-free survival among that particular subset. And then also, of note, pneumonitis numerically was twice as high with the internal mammary node radiation, but it wasn't a significant difference. So in conclusion, this was a negative trial. They were not able to show across this entire population that you can improve disease-free survival by 10% with the inclusion of internal mammary nodes. So even though I feel, this is my personal opinion, in the breast cancer world, we're actually much more apt to be lumpers than splitters for whatever reason. After some of the recent regional nodal trials came out, we started treating every single person all regional nodal for anyone that met inclusion to those trials. Never really thought about splitting. I think the author's takeaway from this was to be a little bit more of a splitter and really heavily consider not including the internal mammary nodes for laterally located tumors, particularly, of course, whenever you're struggling at all with heart or lung dosimetry. And I think this is hugely important for us to consider. I don't know how often other people are already doing this, but both where I trained, where I work now, it's never done. It's if you either do regional nodal, including internal mammary, or nothing. So I think this is a very pragmatic, logical approach to treatment.
Yeah, I would to echo that too. It definitely helps reinforce in practice, making decisions based off other patient factors. So I guess in contrast to what you mentioned, I will sometimes look at, whether to omit the IM nodes on, let's say it's a left-sided breast cancer case and it's a well lateralized tumor. I think maybe, you can't directly take this from this trial, but it kind of leads you to conclude that possibly those patients derive a less benefit from internal mammary radiation. and that at least there's no dramatic difference in disease-free survival for those populations.
Yeah, I think that's very sound thinking. You know, and you're going to have people that are in different camps that feel strongly, but I think it's really logical in a lot of ways. And if you look at the extended radical mastectomy series, there's a clear correlation between positive IM nodes and laterality of the primary tumor as well as axillary lymph node burden. So more axillary lymph nodes, more medially located tumor, that risk is pretty high, and somewhat perplexingly oftentimes exceeds what we see in terms of recurrence risk there. But I think it makes a lot of sense to think about this. And I think if you look at the existing data that's out there, whether it's the French study that you discussed, that showed randomized study including IMN or not, no overall survival benefit. But there's some criticisms of that study. 25% of the patients were lymph node negative, and it was 2D planning, so maybe the coverage wasn't great of the IM nodes. There's criticisms there. And you've also got the prospective Danish study, which if you had left-sided breast cancer, you did not get your IMNs treated. If you had right-sided, you did. And although it was not randomized, it was prospective, and they did see a survival benefit. So, I definitely think there's probably a subset of patients that benefit and probably a subset of patients that don't. And I think this helps you to make good decisions for your patients based on looking at their overall picture. Because, with breast cancer, oftentimes you're thinking about the overall health of the patient, and, other factors such as cardiac health and things can come into play. So that makes sense to me.
I guess the one final point is the really fortunate thing about radiation is we get to perseverate on it so long before we actually pull the trigger. So, I think it also makes sense to default to including the IMNs, but once you get into planning, if you're really struggling with your dosimetry and someone clearly doesn't have an extremely high axillary nodal burden or a medial tumor, I would have a very low threshold for just coming off the coverage for IMNs. So that's another, it's just really good to have this data kind of in the back of your mind.
Yeah. So the next study is the ORATOR 2 study by David Palma. Laura, you want to do this one?
Sure. You can go to the next slide. So some of you may be familiar with the initial this ORATOR 2. So what's ORATOR 1? The first trial was reported a couple of years ago, maybe at ASTRO, I don't remember, which was comparing kind of our standard definitive radiation approach with an upfront TORS, transoral robotic surgery approach to early stage HPV positive or pharynx cancers. Most of us know TORS has really become a popular way to, quote, de-escalate. That's the goal of TORS, is to de-escalate kind of surgical therapy for and recovery for these cancers that we all know have a very good prognosis with our standard treatment algorithms. And what the initial ORATOR trial showed was that dysphagia was actually better with an upfront radiation approach, which maybe at first glance seems counterintuitive, but the majority of these patients after TORS required adjuvant radiation anyway. And so, of course, a single modality treatment plus or minus chemo, depending on other risk factors, really seemed to portend a better quality of life outcomes for these patients than TORS, than adding adjuvant therapy. So anyway, that's kind of the first iteration of looking at how do we approach what's the best without compromising cancer outcomes, what's going to afford these patients the best quality of life. So ORATOR 2 was similar. So it looked again at these early stage HPV positive oropharyngeal cancers that were all, candidates for TORS, and they were randomized either to TORS or this time radiation was slightly de-escalated from the 70 gray, historical standard to 60 gray, conventionally fractionated. The primary endpoint, interestingly, was overall survival. I would think that would be less of a question, I guess, although you want to show that the de-escalated radiation isn't going to impact survival. But what was found is, it's a relatively small trial with 61 patients. In the end, that was closed early to accrual because there were 2 postoperative deaths, which were very unexpected. One was due to a hemorrhage that became uncontrollable, and another one, interestingly, to cervical osteomyelitis that led to sepsis and death. So, what ended up happening is closed early, and there was a survival difference in favor of radiation, actually, because of the surgical complications. Of course, 2 post-op deaths could certainly be a fluke. I think most surgeons would say that wouldn't happen to them, right? So I don't know if we really should make much about the survival difference, but I think what is the main bigger takeaway is that the progression-free survival at 2 years was 100% in the de-escalated radiation arm. So regardless of the kind of comparison between the two, I think that this does certainly add to confidence, adding to HN002 that was reported a couple of years ago at ASTRO, that stopping at 60 gray definitive radiation for these HPV positive early or pharyngeal cancers certainly seems safe and effective. And, coupled with the comparison here, and particularly the first ORATOR trial, it actually may, I think all data at least points to it leading to better quality of life outcomes for patients as well.
I think this just adds to the increasing body of literature about different strategies and attempts to de-escalate therapy in this patient population. We know that they are prognostically doing better with standard of care treatment, and there's a lot of interest in how to de-escalate therapy. We've got the RTOG 1016, as well as de-escalate, that tried to substitute cetuximab for cisplatin, and that was inferior compared to cisplatin. You've got HN002 looking at 60 gray with or without chemo, using ultrafractionation in the radiation alone arm, both having great outcomes. There's a lot of interest here, ongoing NRG study looking at this. And so, I think we're gaining traction. When we asked Dr. Palma himself if he thought that de-escalation should be standard of care for patients, he said, not yet, not for him. He wants phase 3 data, but did state that it's reasonable if you wanted to, based on a large phase 2 such as HN002. So this is interesting, and it was interesting to get his take on it too.
Okay, so the next one is definitely very potentially practice changing, probably more than most of these others, just because of how big of a paradigm shift it is. But this was done by Dr. Ma and colleagues at Mayo Clinic, looking at de-escalating adjuvant radiation, again, for the HPV positive or pharyngeal cancer patients. So this is, if you're not familiar with this trial, you'll have to bear with me for a second, because it is, like I said, a pretty big paradigm shift. So this was a large randomized trial that was based on a single arm phase 2 trial where outcomes were very good. That's kind of where it was born. I think that was reported a couple of years ago. So nearly 200 patients were enrolled after TORS resection of an HPV positive or pharyngeal cancer. So everyone did receive TORS at Mayo. So they didn't receive TORS anywhere else, which I think is probably important. And it was very, very inclusive. It virtually included all patients after TORS. The only notable exceptions were T4 pathologic T4 tumors, or if you needed more than one re-resection for tumor on ink. You were excluded at that point as well. So virtually every other patient was eligible for this de-escalated adjuvant radiation trial. And they're randomized in a 1-to-2 fashion. So, the control arm getting the standard 60 gray adjuvant radiation with concurrent cisplatin when called for. And then the other group being randomized to this de-escalated regimen. So the de-escalated regimen was done in only 10 days. So the patients came for 10 days of treatment, which is the biggest thing to remember here. It was delivered twice daily. So the volume typically received 1.5 gray twice daily, and there was an SIB boost 1.8 twice daily to areas of extranodal extension. So again, extranodal extension was not an exclusion for eligibility here, but they did get somewhat of a dose escalation during adjuvant radiation. And then also, very importantly, the concurrent chemo here was a low dose docetaxel, which also, that was eyebrow raising for us, because of course it's beating our head at this point that you have to give concurrent cisplatin for these head and neck cases. But this is based on some early basic science data that was showing that docetaxel is particularly effective for these HPV positive oropharyngeal tumors. And then again, it was borne out on phase 2 trial data. And so that's the regimen that they used. So they got the chemo on the first day of the week each week. And then another really important point that wasn't really discussed much in the abstract, but that Dr. Ma brought up, was that contralateral neck radiation was virtually never included unless the primary tumor apparently crossed midline, or there was actually contralateral elective radiation was never used unless the primary tumor crossed midline, which I think is a very, very liberal kind of de-escalation of volumes. And so the primary endpoint was grade 3 plus toxicity at 3 months, and it was significantly improved with this de-escalated therapy. And then all of these secondary endpoints were drastically improved as well, including, if you look at feeding tube rate, 27% in standard arm versus less than 2% in the de-escalated arm. And then the most important disease outcome takeaway is that the outcomes were phenomenal across the board, even with the de-escalated therapy, with the exception of N2 patients with extranodal extension did do more poorly with the de-escalated adjuvant therapy. So Dr. Ma stated that this is actually now the standard of care at Mayo, with the exception of patients that have pathologic N2 disease with extracapsular extension. I don't know if you have comments, and then we might have to stop after this one because of time.
I guess it's good to point out, these are, I guess the primary focus of some of these studies were really more the surgical de-escalation, and radiation was a big component of it in ORATOR, but particularly in DART with a different regimen. Obviously, this is pretty specific to certain institutions. I don't know how applicable the regimen itself is to a lot of us in the community, but I think it does kind of show, and also there recently published was the ECOG study that's kind of similar with dose de-escalation with in kind of that intermediate risk group. And I think they both kind of at least get you thinking about maybe patients with intermediate risk factors might have less toxicity and still do just as well with lower dose, but patients with higher risk features, we don't necessarily need to be jumping to de-escalation in those patients.
So Jessica, I'll just ask you, we have 4 more studies that we were going to highlight. Do you want us to run through those in 5 minutes and then leave time for questions, or should we stop now?
why don't we go forward through a couple more topics on your slides, and then I'll cut you guys off at like 11:52.
Okay.
Because I know this has been great just to kind of get these in rapid fire and let folks just kind of be aware of what was out there and what highlights you guys had. There's some great chat, but no questions that are kind of burning, and we'll and I can summarize a couple practical points at the end there.
Perfect.
I mean, I think these are the next few are summarized one-liners. Sabre 5 was basically a follow-up to Sabre Comet that we are all familiar with from a couple of years ago, looking at ablative therapy for all oligometastatic disease. It was basically a prospective look once that trial closed at all patients treated with that paradigm moving forward to get a more real-world grasp of toxicity with these treatments, which is, I definitely applaud the authors for doing. I think that's an amazing paradigm I wish we did more of. But virtually, just if you look at the, I would say just look at the right column. I think the big takeaway from this is the toxicity was exceedingly low. Only 5% of patients had any grade 3+ toxicity, no treatment-related deaths. And I think a big reason for this is, and this is what we should always bear in mind when being more aggressive with oligometastatic disease, is that OAR constraints always trump coverage. We got to keep the big picture in mind with these patients. And so, they actually accepted down to 50% coverage in favor of meeting OAR constraints. So I think that's probably the biggest takeaway. This can be done very safely and just keep the quality of life picture in mind for these patients.
Yeah, and I mean, I think, one other takeaway here is, they were not bound by 5 fractions in their SBRT. And so you just see a couple of 8 fraction regimens and some various options that they use to try to deliver treatment safely in certain sites.
Mm-hmm. Yeah, I was just going to comment on that previous trial. So I really liked the Sabre 5 study being in community practice. I thought it was just a great example of, where we often are with SBRT for oligometastatic disease right now, which is, we had those early studies that showed some exciting outcomes, and now we're kind of waiting for bigger data to come out. And this is just a great example of largely very safe approach to oligometastatic disease throughout the body, performed in a lot of not necessarily large academic centers. It was like a regional cancer group. And so I thought it was a really good study. I've started looking to this trial and protocol for what are good, safe approaches to doing SBRT for oligometastatic disease in the community. And it's a really large study as well. So I think that's another big takeaway from it. So I thought this one, amongst a lot of the studies, has a lot of practical aspects for community practice folks.
I guess one really small other takeaway that's really important is the authors did mention that most of the higher grade toxicity was liver and adrenal, which I think makes a lot of sense. Those are very, very challenging locations to give very high doses with appropriate immobility. So I think I would have a higher threshold for being very aggressive in those locations. Okay, so
size study.
So basically one-liner. So this looked at oligoprogressive disease. So patients who have been on systemic therapy is an extremely broad population, but all had non-small cell lung cancer or breast cancer, could be on systemic therapy for any amount of time with any amount of disease. But if there were only 5 or fewer lesions that were clearly progressing, they could be enrolled. So very, very, very broad population. We come across this all the time with med oncs who are coming to us say, I really don't want to change their chemotherapy. Is there anything you can do? What was very interesting was among the non-small cell lung cancer group, which had 58 patients. If you look on the right-hand column, their median progression-free survival, which was the primary endpoint, was multifactorial times higher, longer with the ablative SBRT approach. So from 9 weeks to 45 to 44 weeks. So for non-small cell lung cancer, it was making a huge difference in delaying any type of need for a switch to systemic therapy, et cetera. But for the breast cancer population, there was actually no difference whatsoever if they received treatment upon oligoprogression or not. So it's a very promising approach for non-small cell lung cancer population.
Yeah, I think it kind of emphasizes the importance of the population and how, yeah, oligoprogressive disease it's just so broad, and it's much more challenging to define clinically. I thought this was also a very good practical study right here, because a lot of us deal with this every day in practice, making these decisions. It is exciting to see that, even in oligoprogressive disease, we can make a big impact in non-small cell lung cancer. So I'm excited to see more of that data in the future. And then definitely interesting to maybe know why in breast cancer that just wasn't the case.
Yeah, I think one of the interesting sort of underlying things that Dr. Sy mentioned to us when we talked with her was that, there's really this thought that there's a true biologic state that represents oligometastatic disease, where there is a degree of almost homeostasis with your immune system and the extent of your disease. Whereas it's less clear that the science supports a biologic state in oligoprogressive disease. And we just have a lot more to learn about who are good candidates for this therapy.
And I guess from one other comment we had kind of discussed was, and this is very anecdotal, but, with non-small cell lung cancer, with what you see radiographically from disease burden, are you kind of truly seeing the full picture, as opposed to with breast cancer? Is there a lot more disease that you don't see? And maybe that's why chasing after lesion, one lesion after another is not so beneficial there as with non-small cell lung cancer. You kind of see what you get more.
I think we could stop there.
Yeah, thank you guys so much. I think kind of as we had some really kind of nice discussion in the chat. And I think, one thing that you guys highlighted in kind of the early discussion is this idea of like, how much data is enough data? Like, we all get lots of data. And that was something that kind of resonated in the chat group as well. And so I think, not to put Caleb too much on the spot, but we had some comments from Dr. Roberts and Dr. Russo and Dr. Ansher that were like, late toxicities or late toxicities. And so for hypofractionation, it's kind of that question of like, how much data is enough data and how long? And so as community folks, I think we sometimes hold the data to a higher standard because we recognize that we want to be practicing this, whatever is the current standard of care. And those things we have to kind of cautiously change. And so kind of what are your guys' takes on, particularly Caleb, from a community setting, like when you are making the jump to change, like how much is enough?
Yeah. I mean, I think a lot of people in the community would say that is a great study with the hypofractionated radiation, but it's only 24 months. So it's a good start in making people feel comfortable about it. On the one hand, it's not in isolation. The dose per fraction is the same as 70 gray and 28 fractions. So in theory, a lot of us have a lot of experience with along those lines of dose delivery per fraction, and it's less than that total dose. So it should be somewhere in that ballpark, I would expect. A lot of it, honestly, I think goes into when you get a feel that maybe a lot of other people are starting to pick up on it at maybe academic centers, and the more and more people that you see using it can increase the comfort level as well. So I didn't feel like I was going to be jumping to it right now. I'm sure it will become standard at some point in the future, but it may be something I would with the short-term follow-up, I might feel more comfortable if I have someone who just has a significant burden with travel and there's just no way they can come for 7 to 8 weeks, then I might actually consider it in someone like that. But I guess a lot of talking to say, yeah, if the trial comes out with, 5+ year late toxicity and everything looks, in line with what we saw with the intact prostate hypofractionation trials, then I would feel pretty comfortable that we shouldn't expect something out of the ordinary that we didn't see in those studies as well.
Wonderful. Thank you so much. And I think the kind of next and kind of final question that we might have is for Laura. Dr. Roberts made a comment in our chat here of, kind of maybe we should have never jumped to IMN coverage. And so utilizing the current data, how do you, who are your common, maybe the question for you, maybe who is it that you feel maybe more comfortable not treating those IMNs in your kind of current practice?
Well, I'll make the caveat that I do work at Sloan Kettering, so I do it the MSK way. So I actually am going to do it probably all or nothing for the time being. But I would say, just personally, I would feel very comfortable, and I would certainly bring it to chart rounds, and I think make a case if I was having, again, I would default to including it, because why not just see what the plan looks like. Mm-hmm. And for pretty much all patients that are getting regional nodal. But then I would feel very comfortable if I was having challenges meeting my constraints for someone with N1 axillary disease that was laterally located. And I think, a big point to make is, and we all probably that treat breast know this, the vast majority of tumors are laterally located. I think it's less than a third of women that have centrally or medially located tumors. So this is potentially an option for a lot of women. And I would feel very comfortable omitting IMNs for someone, that, again, N1 disease that's clearly laterally located that had a axe dissection.
Yeah, I would. Oh, I'm sorry.
Ahead.
Well, I was just going to say, so I typically, if it's a lateralized, like upper outer quadrant breast cancer, 1 positive node, or 1 or 2, I a lot of times do not treat the IM nodes. If they have a more medial central tumor, or with a lot more nodal burden. So if they have over 3 or 4 lymph nodes, then yes, I'll pretty much always try to include all the comprehensive nodes in those cases.
And I do agree with Dr. Roberts' sentiment of being selective, and I think it definitely makes a lot of sense. But I also understand the fact that the 3 original post-mastectomy studies with the Danish and British Columbia, as well as MA20 and the Portman study, all included the IMNs. And so I understand if you want to stand on the existing data, that is where we've seen it originally done and time again demonstrated. But I think it allows you to be a little selective.
Yeah, but I think you can use some anatomic common sense too, and in certain situations, when to include it.
Excellent. Well, thank you guys again. And I'm just maybe in closing, could you remind us if we wanted to sign up for the QuadShot newsletter, where we could, what's the best way to do that?
So you can just go to quadshotnews.com and there should be a big subscribe button. And then it also archives all of our prior blurbs. If you ever say, oh, I read something in QuadShot about this, you can put it in the search box and try to find it to refresh yourself.
Wonderful. Well, Sam, Laura, and Caleb, thank you guys so much for coming to join us and preparing these and adding the commentary from the speakers that you guys got to chat with. It was a really nice review of ASTRO, and thank you for everybody that commented in the chat. I think that was helpful to see everybody's perspectives. And we look forward to seeing you at additional ACRO webinars and then hopefully in person at the ACRO meeting. Have a great afternoon, everybody.
Thank you.
Thanks.
Thank you.